Καλησπέρα σε όλους. Θα μιλήσω αγγλικά λόγω του προσκεκλημένου μας. It gives me a truly great pleasure to introduce to you Danilo Neglia. He's a world authority in cardiac imaging. Danilo wears many hats. It's not possible to list all of them now, but I will just say that he is the director of multimodality cardiovascular imaging program in Fondazione Toscana Monasterio in Pisa, and is also an associate researcher at the Institute of Clinical Physiology at the National Research Council, again in Pisa. He is the driving force and the man behind the well-known EVINCI study. He's a central figure at the SMART Tool project, and also is again the man behind the EURECA registry, this very important EU-funded project. Above all, is a great scientist and a very cultural man, and it is an honor for me that I can call him my friend. So without further delay, I would like to invite Danilo to the podium to talk to us and give us his wisdom, Danilo, on non-invasive imaging, or share with us your wisdom on non-invasive imaging in stable coronary artery disease. Danilo.
Thank you a lot, Dinas, for the kind introduction. And we are long-lasting friends since a lot of years. And also thanks to all the Hellenic Society Board for this kind invitation. And what I would try to do in the next minutes, even if we are, I guess you are tired for a long and successful Congress, I would try to summarize what are my views, at least in general, the views about multimodality imaging in coronary artery disease. I'm sorry that my Greek is absolutely absent, and so I have to speak in English. So, what could we say about multimodality imaging and its evolution? I would make a parallel with the Italian food. So, as you may know, I don't know your preferences. I like a lot of Greek food, but I think that you could like also Italian food. And there are differences among having single shops in Italian food. These are very ancient shops where you can buy very specific pasta or very good champagne or spumante. Or more recently, probably you know, there is a chain that is spreading all over Europe, and not only Europe, which is called Italy, which means Eat Italy. That is a so-called we can say multimodality shop. So what do you prefer? Ancient one-stop shops or a multimodality shop? So I would not discover my preferences since the beginning. We will discuss at the end. Now, what is multimodality imaging? This is how we defined multimodality imaging recently in a paper coming from the Task Force on Multimodality Imaging of the European Association of Cardiovascular Imaging, the European Society of Cardiology. The first point is that multimodality imaging doesn't mean that we have to do many imaging in the same patients. It's absolutely the other way around. So we define it as imaging of the heart based around the patient and their disease, pathology, and presentation, which utilize information coming possibly from more imaging modalities, but can be performed separately or in combination, but in particular, when they may offer the most clinically effective and most importantly, cost-effective approach to the problem of the patient. So we can solve with one imaging modality, more imaging modalities, but the problem is that the patient should be in the center. Now, as we all know, we have many different possible approaches to a patient with a suspected coronary artery disease. A different imaging modality give different information on the patient. For example, we may have different levels, a different severity of the disease, starting from the involvement of the microvascular or endothelial system, and imaging modalities, functional imaging modalities, as for example, perfusion studies or let's say flow reserve study, even with Doppler echocardiography, may evidence the presence of an impaired flow reserve, which is an hallmark of maybe an hallmark of coronary microvascular dysfunction. Then we may have atherosclerosis. And now we have a simple way, a very effective way to look at the whole burden of coronary atherosclerosis by CT angiography. But then the disease may progress, and may progress towards obstructive coronary artery disease. And we may look at obstructive coronary disease either anatomically, looking at the stenosis, for example, with CT angiography, but we can also look at this disease by its functional consequences using functional tests such as stress echocardiography, stress resonant magnetic resonance imaging, or the nuclear cardiological approach. And all of this can give the information on the functional significance of obstructive lesion. But more recently, we can also try to combine the anatomical information with the functional information, such as, for example, by new advancement in CT imaging, which not only depicts the coronary anatomy, but can depict also the functional significance of that lesion by the so-called FFR-CT approach. Or you can combine CT with perfusion imaging in what is called hybrid or fusion imaging, where you see the stenosis on the coronary angiography and you see downstream the perfusion effect of that stenosis. So we have really multiple modalities that can depict almost all that we need to know about the disease of this patient. But why should we do imaging? We should do imaging with specific purposes, not to have nice images. I like a lot this kind of images, but it's not our goal. Our goal is to use imaging to decide if we should treat the patient, how to treat the patient, if we should go to invasive coronary angiography and perform revascularization, and in particular, imaging is S-value if it is demonstrated to improve patient outcome. So this is our goal. Now, and you see that the pyramid of evidence in imaging has changed over time. In the beginning, we used the competitive imaging modalities to make a good diagnosis of our disease. But now, doing the diagnosis is only the first level. The second level is to evaluate if we may have benefit on symptoms by imaging-based treatment, if we may improve prognosis, but also, we must use this in a cost-effective way. So, which are the fields that we will briefly cover now, which are the questions that are posed to the imagers and to the cardiologists when we face a patient with suspected coronary artery disease. The first one is to diagnose if there is actually a coronary disease, then to stratify the risk of that patient, and based on the risk stratification to guide treatment to improve symptoms and outcome, and we should do this in a cost-effective way. Now, let's take an example. This is a clinical case which comes from the Vinci study that Dinos was mentioning. She is a patient coming from Spain. She has 50 years old and comes from a low-risk European region. She has some cardiovascular risk factors, hypercholesterolemia and hypertension. Sorry? You think older? I was thinking younger. It depends. However, the picture, of course, is not the real patient, so I try to match it. But the real patient is that I'm describing. Now, she has hypercholesterolemia and hypertension, and she has symptoms with a gene angina on effort and at rest since 6 months, so it's relatively recent. She is under treatment for hypertension, and for hypertension, a preventive treatment. She has a low HDL level. She has a negative T-waves on CCG and a normal echocardiography. Now, what should we do in this case? Looking at the European Society of Cardiology guidelines, 2013 guidelines, the first thing to do is evaluate, based on this data, which is the pretest probability that this patient, this female patient, has of having an obstructive disease. So we could, let's say, guess which could be the probability, but actually you can use the tables that are included in the European Society of Cardiology guidelines, which is the Diamond and Forrest modified table in which, based on symptoms, she has typical angina, on age and gender, you find out which is our probability, pretest probability of disease. This comes to be 47%. Do you think it is reasonable? No. Someone say no. Why not? Is higher or lower than expected? Higher. Correct. Problem is that evidence now, very recently, is showing that the pretest probability, the models by which we predict pretest probability in Europe, at least, are not working actually. This is, for example, coming from the confirm registry. Actually, it's been done mainly in US, but also in Europe. And you see that for any gender, this is men, these are women, and for any type of symptoms, the pretest probability is the light gray columns. The actual present obstructive disease is the dark columns. So the obstructive disease is much lower than that predicted. In our case, this female has a lower than 20% probability of having disease. So this is something which could be addressed in the next guidelines because the evidence now is clear. And there is another study, very recent study, data from the PROMISE study that say the same thing, that the Diamond and Forrest corrective probability is absolutely overestimating the actual presence of disease. So our patient, according to these data, have much lower probability than expected. Now, since we have these, there are some new models that have been introduced. For example, this is one that has been produced by the Vinci study, and you see that taking patients with intermediate probability of disease and applying a more sophisticated predictive model, which includes some biomarkers, you could reclassify this patient, and 50% of this patient would be reclassified to low probability, which means that 50% of this patient should not go to any imaging modality at all. So you think, just to know that things are changing in our environment. Now, based on what we know, this is the only question for the audience, what would you choose as the next test, the first test? So who votes for exercise ECG? Raise hands. 2. Who votes for stress echo or CMR? Other 2. Who votes for stress spectral PET? Of course, the nuclear are going. 4. CT choreangiography? 5. More. And invasive, direct invasive choreangiography? No. So the most of you selected CT angiography. And based on the clinical guidelines that we have, we may have 2 choices actually. We can go to exercise ECG or stress imaging, but if the probability is estimated to be lower than 50%, would be possible and also advisable to do CT angiography. So your choice, the majority of choices are correct. And actually, if you look at the NICE guidelines, it's coming from UK. Of course, UK in general are going in the other direction, not only by driving, but this is a little bit different from the European guidance. They let's say, recommend to use CT angiography not only in low probability of disease, but in all patients coming with typical or atypical chest pain as the first test. So let's see what happens and why. Actually, you see that the comparative accuracy of different imaging modalities in older studies are roughly comparable. But in new population with lower prevalence of disease, CT angiography comes to be a little bit better than other studies. The reason is that the negative predictive value of CT angiography allows to exclude the majority of patients which turn out to have no colorectal disease. This is the reason why the accuracy is, of course, better. Now, let's see our patient. If we should have done stress ECG, this is the result. I don't know how you would judge it. I would say that this is positive, but probably not high risk. If we do CT angiography, this is the results. There is a lesion here on the left anterior descending coronary artery in the middle part of the left anterior descending artery. There is another lesion here at the origin of the circumflex artery. The right coronary artery is normal. Now, based on these, the third question that we have, the first is which is the pretest probability, second, do a diagnosis. We did the diagnosis because CT showed coronary artery disease, but the third question is which is the risk? And if we look at this angiography, surprisingly enough, it is not high risk. Based on what we know, it is intermediate risk pattern. And this, what does it mean? That the prognosis is intermediate risk. And according, we know that CT angiography is very, very able to stratify the risk in patients. And you see that normal coronary arteries are lower risk than non-obstructive disease, then obstructive disease, 1, 2, or 3 vessels. So it's very clear. But it's also clear that the composition of the plaque also stratifies the risk. So CT angiography, for sure, is able to define the 5 years risk of the patient. But the question is, does it stratify the risk related with obstructive coronary disease? This is a completely different issue. So for this issue, this patient has intermediate risk. And for the guidelines, you could choose if we're giving optimal medical therapy and waiting or going to invasive coronary angiography. So treatment could be optimal medical therapy. This is the fourth question. And actually, it works. This is very recent results from the SCOT-ART study. And in the SCOT-ART studies that has been performed in Scotland, as the name says, the patients were randomized to have usual care, including functional tests, or be submitted to CT angiography as the complementary test. And they followed the patient for 5 years. The results of the long-term follow-up shows very clear results. The patient that had been submitted to CT angiography first had a better prognosis than the patient treated in standard care. How does it matter? How may it happen? The coronary vascularization were similar in the two groups. So this effect was attributed to the fact that general practitioners were giving aggressive treatment, medical treatment in patients which had positive CTCA. So it's mainly due to medical treatment and not to other issues. So, but we may have answer to the same question, which is which test preferred, even in another way. Let's do another path. And in this case, let's select not ECG, but stress imaging. We could have done either stress echo or stress perfusion, as in this case. This case has all these tests only because it's for research reasons. They should go by protocol to different modalities. Now, what happens if we use this test? As you can see here, the scintigraphy is clearly positive for inducible ischemia, and the stress echo is also positive for inducible ischemia. You see here a exercise-induced ball motion abnormality in this region. So both tests are positive for inducible ischemia. And this is what happens when we use different tests in patients with different pretest probability of disease. You see that stress echo in this very recent meta-analysis, stress ECG is not performing very well. This is higher probability, this is lower probability, and this is the post-test probability. So stress ECG is not very good in ruling in or ruling out disease in most of the cases. You see that stress imaging, on the other hand, is much more able to rule in or rule out disease, as well as CT angiography in these patients. So this is why we should prefer stress imaging to stress ECG, where this is possible. This is not in keeping with the American guidelines, which still recommend stress ECG as first test. Now, in this case, we see that stress echo is positive in more than one territory, and we have at least 3 segments, and this, by definition, defines high-risk ischemia. and the prognosis is high risk. If you look at the scintigraphy again, we have a large perfusion defect here, which is much less in resting condition, so the inducible ischemia is very extended, and this means that there is high risk. According to these high-risk patterns, we should go to invasive coronary angiography and possibly revascularize the patient. There are multiple studies that show that inducible ischemia has a great prognostic value, either if we use a stress echo by exercise or we use stress echo by pharmacological stress, and there are compelling data saying that when we have an abnormal myocardial perfusion imaging, the prognosis is almost 6 times worse than patients with normal scans. And if you quantify also the flow, the quantitative flow reserve, as can be done by PET or more recently by SPECT, adds more prognostic value even on the regional ischemia pattern. So, coming to our case, if we should have done one of the stress imaging modalities, we should have had a clear indication to go to invasive coronary angiography. This is the result of invasive coronary angiography. You see there is a tight stenosis in the middle third of left contra descending artery. Is a stenosis here. On the circumflex artery, there was FFR was 0.77. Now, the last question to the audience is, how many of you would have revascularized LAD? Almost all. And how many of you have revascularized circumflex artery? Only 1, 2. Good. Actually, if we look at the images, when we merge CT angiography with perfusion imaging, for example, you see that downstream the LAD stenosis, there is a clear perfusion defect. But if we look at the circumflex territory, that is this one, there is no perfusion defect. So actually, that lesion on the origin of circumflex artery was not causing ischemia, strangely enough, but is that the case? And also the value of FFR, which is 0.77, according to the very, very recent revascularization guidelines, is not enough to recommend revascularization. In fact, you see here that the new guidelines say that FFR should be lower than 0.75. So it's roughly that, but there is not a clear recommendation to do this revascularization. That is also a complex procedure with many risks. So we would take the risk without having the benefit of reducing ischemia because there is no ischemia downstream. Now, we used to say that combining the anatomical information with the functional information, we really may define better the condition of the patient. As in this study, you see that merging the CT angiography made first. So you make first CT angiography if it's normal, okay? If it's obstructive, it's non-obstructive, okay? If it's obstructive, you go to stress imaging, perfusion imaging. If perfusion imaging is positive, the prognosis is really worse than being negative. So this means that when you combine information before invasive coronary angiography, you would better select a patient that would improve after vascularization. This is the classical study by Akamovitz that says that when you revascularize, you see here, patient with a lot higher than 10% ischemia in the myocardium, you improve prognosis. But if you revascularize patient with no ischemia or low levels of ischemia, you could even produce an unwanted detrimental effect on prognosis because there is no gain in that revascularization. And again, the FFR guided treatment, as was demonstrated in the FAME2 study, again, if you revascularize patients with depressed FFR, you gain prognosis as compared to patients which are not revascularized. So there is compelling evidence that when we revascularize a functionally significant lesion, this will do the difference. But the problem is, do we do that? These are the results from the Vinci study, and you see that on the right hand, you have patients that had obstructive disease with matching perfusion defects. How many of these patients have been revascularized? Only 70%, which means that 30% were not revascularized. On the other hand, patients that had not matching defects between perfusion and anatomy were revascularized in a substantial portion. So we do not behave as the guidelines would say. And this turns out to be important for prognosis. This is a study recently submitted a few days ago to the American Journal, and you see that if you take patients without coronary artery disease as CT, they have a good prognosis. If you take patients with coronary artery disease, if they are treated appropriately, have a better prognosis than those that are treated inappropriately. So it means that if we take into account both the anatomy and function when we decide treatment, this makes a difference on prognosis. Now, where time is up, so we will only have a few slides now, and there is the fifth important question. It is that our approach is cost-effective. Actually, there are not clear evidences of this, at least. And an approach like this, you do CT first. If it's normal, you go to optimal medical therapy. If there is atherosclerosis, not obstructive disease. If it's pathological, you go to stress imaging. If it's normal, to go optimal medical therapy. If it's possible, you go to invasive angiography. And if it's confirmed, you go to PCI. This could be reasonable, but there is no data that say that this is cost-effective. We have a preliminary data here, again, from the study that I mentioned before, and you see that a strategy using CT first and stress imaging, if the CT is positive, is better in terms of diagnostic yield of coronary angiography and also revascularization procedure. But this question is open for discussion. Just to mention what is the future. One of the possibilities in the future is to have some added let's say, help from computers in our decision making. And the use of machine learning approach is becoming more and more important. This is a study that will be completed in 6 months, where we use symptoms, risk factors, and laboratory data that in the future could be gained also on a lab on a chip, which means that you could do that on your desk. You merge these to have a better predicting mode of disease. Then you do CT, analyze CT for multiple parameters, and you could predict the evolution of disease, and on this you can, let's say, guide treatment. This is futuristics. We will see if it will work. Another approach is to use the one-stop shop. For example, using CT, as I said, by functional measurements such as FFR CT, that has been demonstrated to be very effective. And you see that this is a normal approach in which you go to invasive coronary angiography and you find out that 70% of patients may have normal coronary arteries. If you do CT and FFR first, you find out that only 10% of patients will find to have normal coronary arteries. So this could be very, very useful. And you can also use hybrid imaging, as I showed before, and new calculation of FRCT by very much usable and speed up processes that are ongoing. But definitely we need new research. And in this end, we are running a new registry in Europe that will start in April 2019 to look how happens, what are we doing in different centers in different countries with patients with suspected coronary artery disease. And since we know that the practice, our practice is very variable, in my country is variable also from one city to the other city, from one institution to the other institution. So we want to monitor what we do and what are the effects on cost and outcome on these patients. And so we will test the adherence to the ESC guidelines in this registry, but we will have also another proposal to be run in 2020, 2021 to create a large European registry of bioimaging registry to put all together and to see by machine learning which would be the best model to predict outcome and to guide treatment. You see here that there are many countries participating, more than 26 countries. We have more than 120 centers, and you can see that Greece is very well represented. This is only, should be updated. There are more than this, but in Greece there are many centers which are adhering to this protocol. That, as I said, will start in 2019. So all of this needs to have a teamwork. And teamwork, for example, in European Society of Cardiology, within the European Association of Cardiovascular Imaging, has been fundamental for many research and also educational process. And you see here that many eminent Greek researchers and cardiologists have fundamentally participated to, and are still participating to this process, and we thank them for all their work. Now, we will have some initiatives that I encourage you to participate in by the CVI. We have congresses, we have certification process, webinars, and also online educational systems. And there will be a next appointment will be the ICNIC Congress, which is a congress putting together nuclear NCT, let's say, issues that will be in Lisbon and next May. So, thank you very much for your attention, and thank you for the invitation.
Thank you very much, Danilo, for this very illuminating presentation. Maybe a couple of questions from the audience, if you are kind enough to accept it, but no more because we are pressed for time. Well, it seems that it was all very clear and it was fantastic, so thank you very much, Danilo, once again.